Welcome to the Dr. Shawn Tierney podcast. My name is Shawn Tierney, and I am a neuromusculoskeletal sonologist. I treat athletes and high performers. My goal with this podcast is to help you make better decisions regarding your health, athleticism, and all aspects of life. Here, I'm both a student and a teacher. Thank you for tuning in. Welcome to the Dr. Shawn Tierney podcast. This is Dr. Shawn Tierney. I'm here today with Dr. David George. He's a specialist with integrative psychiatry and neural rehabilitation. So just a really interesting field. Therapies that he's offering are new to me, new to my knowledge, and outstanding, innovative in many ways. Also, he's kind of coming into my field with being a practitioner of stellate ganglion block and C100 dissections and other ways that we traditionally modulate the nervous system. So from here, let's hand it over to David George and just tell me, how you got here, what's your passion, what are you working with? I know, where are we going, okay?
Sure. I'll tell you a little bit about myself. But first, I was going to say thank you very much for having me.
Yes.
It's always great being around you, Shawn. And one of the things that you didn't mention in that introduction was how much I've learned from you. So every time I'm around, I learn a lot, and you tend to attract a lot of great people. So I always end up meeting a bunch of great people around you and learning a bunch from you. So I really appreciate that opportunity.
Oh, it's my great honor.
So integrative psychiatry and neuro rehab, that's a practice that I have in Phoenix. And what that is based on is an idea that in the field of psychiatry, so dealing with problems like depression and anxiety, there are many roads to Rome. So much more that we can use to improve brain function and improve symptoms in these types of conditions, more than just prescription medications and psychotherapy. So we're looking at things like metabolism and in my case brain rehabilitation, because I come from a brain rehab background where for almost 20 years I've been teaching brain rehabilitation as a clinical instructor in clinical neuroscience, and the idea of integrating those two fields together, that's kind of where my career is led. I've been very fortunate and passionate about the intersection of those two fields, the idea of improving brain function to improve people's function overall, especially with respect to behavior and emotional well-being and physical well-being all at the same time.
That's super interesting. And what I've learned is that the traditional psychiatry has one path, but then there's integrative psychiatry. Now we're actually focusing on different parts of the brain. It's a little bit more nuanced, it seems to me, a little bit more detailed, and I kind of tend to gravitate towards this more detailed, more functional approach, because I think it tends to lend its ability to have more success and more consistently.
Yes.
Because the more precise we can be, the more consistency we can produce.
Certainly. I mean, in the field of psychiatry, if we look, for example, at a prototype disorder like depression, for example, it's very common. About 40 to 60% of people that experience depression are going to have relief from psychotherapy and prescription medication. But if you look at that statistic, the exact inverse is true. 40 to 60% will not. So there's a persistent unmet need in that field for disorders like anxiety and depression. There's a lot of people that don't get better with your frontline therapies. If you look at concussion, for example, and this is where these two fields have intersected for me, because I spent a lot of my career dealing with brain and brain injury. In concussion, for example, about 15% of people with concussion are going to have persistent symptoms afterwards. 40% of them are going to end up with depression and or anxiety after a concussion. So if you take that 15% and the 40%, it means that very many of the people with the 15% that end up with these persistent symptoms after concussion that don't resolve end up with persistent anxiety, depression, these vague kind of symptoms and emotional problems after these concussions. Now, in a sport like you and I had the privilege of attending to a world-class athlete here recently. I don't want to say his name, but here recently, just this past weekend, and this is a surfer who's had multiple instances in his career, which is very typical, where you can remember getting his bell rung. Well, each time you get your bell rung, there's that 15% chance that you can end up with persistent symptoms. So it's just like, don't roll a number 6 on a dice. Each time you roll that dice, you got a bigger chance of hitting that 6. And for a lot of people, that means that there's a huge population of people in contact sports like surfing and these types of things, where they end up with these persistent symptoms that they kind of write off or accept as normal. And a lot of time that's in the behavioral domain: depression, anxiety, panic attacks, insomnia, emotional dysregulation, these types of things.
So how do you understand the physiology behind this happening? What parts of the brain are being affected, and how do you modulate that? What are you doing that's different?
Well, the first part that I'm doing that is not different is what you and I share in common, and I've had the privilege of being instructed by you and actually helped a great deal, is the stellate ganglion blocks and the autonomic injections in general. So we're talking vagus and up C1, which you're a master of. So that's one example of one of the things that we do. So that's not unique to me by any means. I'm not breaking any ground in that, although the field that we share in that regard is very small. There's a small community of people that are doing that. So that's one example. What we're doing when somebody comes in, for example, with a depression or an anxiety or post-concussive symptoms or emotional dysregulation, even something like burnout, is we're doing a standard psychiatric evaluation to assess, is there some other, problem here, like a bipolar disorder or, psychosis. We rule those things out. But once we've done a comprehensive psych evaluation, then we do a nervous system evaluation. So we're looking in these certain lanes where we consistently find problems, and that is in the autonomic nervous system, in the cognitive domain. So autonomic nervous system is obviously the realm of sympathetics and parasympathetics. And the cognitive domain, so that's your processing speed, your memory recall, and your executive functions. We're looking at those types of functions. Metabolic function we're looking at. And then we also look in the domain of the typical, emotional regulation and those type of things. So we'll do, and this is in a similar approach to as you would get with, say, a neurologist or in a neuro rehab. We're looking for opportunities to, let's say, if we find areas of the brain that are functioning low, we want to bring those up. If there's areas that are functioning high, we want to bring those down. And that's typically a unique signature to each person. No two head injuries are the same, and that has to do with people's unique physiology. So that's generally the approach that we take. And the tools that we use are some of the tools that we share in general: the autonomic injection therapies, as well as neuromodulation, and other therapies, complementary and alternative, and these sorts of things.
Fantastic. Now, when somebody has this this dysregulation, and they have depression, what parts of the brain are you thinking you want to address, and how are you? I know we're doing the stellate blocks, I know we're doing the C1, and you're doing some ketamine, and how do you think about what you're addressing? How do you approach that? How do you kind of focus your treatment?
Yeah, so the focus is based on the assessment. I mean, some of the areas, now you've asked me for specific areas, so I'll try and answer that question directly. Commonly, when we look at the literature on depression, some of the most consistent areas that we find that are hypofunctional, that is lower functioning than we would like, are the prefrontal cortex, the dorsolateral prefrontal cortex, the cerebellum, for example, some hypothalamic. You probably heard of the HPA axis is a very common and kind of in vogue theme in psychology and psychotherapy. You've probably heard of something called polyvagal theory that's out there. So it's a very hot topic, these autonomics. So these are some of the areas. But really, we can't really take that to the bank on any one person. I want to take an approach where I'm saying, okay, look, that's where the majority of people lie, but we don't want to work on averages. We want to treat each person as an N of one and look at their unique signature. And that involves a unique assessment of their nervous system, seeing how their vestibular system is integrating, how their autonomics are regulated, their prefrontal cortex, how can they concentrate on something. We look at eye movements to see how different parts of their brain are integrating. And then we find that unique pattern, and then we plan what to do in conjunction with some of these other therapies there. So it's a great age. I mean, one of the things that we have to tell people in psychiatry, for example, when they're coming in is, if we prescribe this antidepressant for you, we're supposed to tell people, don't expect this thing to work for 5 to 6 weeks. That's standard, right? So if you're in really bad shape and your life is off the rails and you're looking for relief from depression, that's a long time to wait. So that's one area that we're focusing, is in interventions that get people that very quick relief. And you and I shared a couple of those interventions in common. And then also the idea of, the treatment-resistant depression, that's a huge population, is saying, okay, what is it that's leading to this treatment resistance? It's very accepted in the world of, if you look at, anyone can do a lit search right now and see, okay, autonomics and depression, cognitive and depression, and you'll find that it's widely accepted that, hey, people have cognitive problems associated with depression. A lot of them have autonomic problems associated with depression. Yet, in psychiatry, we're not trained that way. We're not trained to do some standardized assessments of cognition. Look at the processing speed. Look at the memory. See where they're at. Look at the autonomics. Let's get some standardized testing. See where they are. Provide the intervention, and then look at these objective metrics. What happens is in psychiatry is we're basing everything on the mood component. Are you emotionally feeling better? Which is such a small snippet, really, you know what I mean? And that's not only is it insufficient in a lot of cases, but a lot of times it's inaccurate, A lot of times we don't want to be asking people, how do you feel now? How do you feel now?
Right.
You can imagine how that can become pretty
it's
fruitless and
super
self-defeating.
Hard to deal with, right? Because somebody can't transition that at a moment-to-moment basis with
Correct.
accuracy.
Exactly.
So just let's walk through like a couple examples of successes you've had, like just no names, of course, but
Sure.
just like tell me the story of this person who has found some relief. Right?
Okay, so fighters, that's a lot of them. I think it's so. Anybody that watches the fight game as a fan or is in that world could probably count immediately at least 5 people on their hand very quickly that this fighter was a certain way. They got their bell rung, they had an injury, and they just weren't the same afterwards. So a number of those cases where people are coming in and they've had panic attacks that they assume to be just, I'm living with these, it's my panic attacks, or they've had nausea. A number of cases like that where those are quite numerous. It's a very, very common one.
So let's just break it down. So like somebody has nausea, and then what's going to be your focus on the treatment, and what's going to be your focus on the panic attacks? Like where? Okay, I know we're probably going to we may do a stellate block, maybe do C1, but you may also say, okay, well I'm going to do some some therapy that kind of opens up a part of their brain, and maybe I'm going to focus on this therapy, this eye movement. This is what I'm thinking when I do that kind of story. So let's look at one person. And
so as a general rule, the idea is this: don't assume that any 2 people have nausea for the same reason.
Right.
And then of course there's a conventional medical exam. We want to be responsible and rule out the easy stuff. So that happens first. Is there some sort of condition that could account for the nausea? In the vast majority of the cases, by the time someone's come to see me, they've seen multiple practitioners, and it isn't an overt, very obvious condition. Right. Then that leads us to the neuro exam. And generally speaking, when we're going through neuro exam, it's like, let's not be biased. Let's kind of do this even though in the history, any practitioner, yourself, anybody, when somebody's talking, you're running that script, and you're like, okay, I think I know what this is, and you're looking to rule things out, like in your differential list. But you want to maintain some degree of impartiality to do a decent assessment, and then look at the assessment and say, okay, which of these deficits and problems that I'm finding correlate with nausea? And in general, as a general rule with nausea, for example, what's happened is the part of the nervous system that expresses nausea or allows you to feel nausea, like the nucleus tractus solitarius, which is a parasympathetic nucleus in the brainstem, typically that is becoming overactive for some reason or another. It could be the vestibular system blasting into it. It could be some form of other overactivity. Autonomics are getting cranked up for some reason. A lot of people that have had head injuries, one of the things that happens is the amygdala, which is a core component of the default mode network, which is essentially like this bubbling pot of negativity at the core of your brain. It gives you fear and anxiety. That amygdala, when it becomes dysregulated because the neocortex is not inhibiting it from above, it'll blast into your autonomics. And when it blasts into your autonomics, you could have things like a little bit of heart palpitations, tachycardia, and nausea. So what we do is we look for that. Is there a dysautonomic component? Is there a vestibular component? How does this correlate with the exam? So that's kind of the process that we'll follow.
Right. And how about with, you talked to this polyvagal theory. Let's go into these little theories. So I know you're looking at this pocket and this pocket. So I'm like, I want to define these pockets so that people that are listening, like, I wonder if that's my pocket. I wonder if that's what my factor is.
Yeah.
And then, now I have somebody that I can figure this out. But let's just get a little bit of understanding on one of these.
Yeah, so polyvagal theory is Stephen Porges is a PhD that's promoted that. But the reason I brought that up is that it is so prolific. It's one of those prolific theories. Trauma and the world of psychotherapy is kind of like starting to entertain autonomic involvement, and the polyvagal theory is one of the entry points that psychotherapists, psychologists, psychiatrists have begun to, say, hey, we can actually touch and feel the involvement of the autonomic nervous system. And generally speaking, it's this theory that in response to trauma, the autonomic nervous system has these stereotypical responses, which are either fight or flight or freeze. That's the theory. And what they'll do is there's this kind of therapeutic approach that looks to essentially enhance parasympathetic function to kind of calm people down and mitigate that response. From my perspective, and I'm sure from yours, an intervention like a stellate ganglion block physiologically gets right to that sympathetic activity and shuts it down, and it's a lot more efficient and, in my view, faster and effective than prolonged therapy. That's not to dismiss therapy, but it means to say is, at least from my perspective, I found a shorter road to Rome to quieten that down.
So, and we definitely have seen a lot of that. We've seen some amazing stories, and I think that that stellate ganglion block and that C1 is like one of the bigger guns we can swing.
Sure.
And I do see this, and I'm not sure this is, I do see this happen where athletes or weight training athletes that are constantly exercising their autonomic system tend to have correction or a little bit of resolution in these cases. So how much of exercise where because I think the one thing I do is I could do weight training, and that's going to increase my peripheral vagal tone, and also maybe sympathetic on one side, parasympathetic on the other side is going to be increased. And then I have also this like high intensity, like a sprint training, which is going to be more central tone, right? So I'm getting my central vessels. So I have this way that I can access this. So we do the stellate block, we do the fine tuning, and then there must be exercises, things that go along with that. And I'm sure you have some, but have you seen a difference with athletes?
Yes. So the way I look at it, there's two. If I can give two examples. So the way that physical and emotional trauma affects the nervous system, what the imaging studies have shown us, and anyone can look this up, is that trauma, intense trauma, whether it's emotional or physical, tends to affect the nervous system in such a way that it's almost like looking through a kaleidoscope. As I'm looking through that kaleidoscope, when I turn the kaleidoscope, I'm now dealing through a different pattern. So once someone goes through a physical emotional trauma, they're experiencing life through a different nervous system. So that's on the negative end. There's call it a distortion of some way, and that can be in various ways. But the same is true of something like, in my experience, and I'm theorizing because I haven't done the studies on this, but the experience that I've had seeing this on patients is it's the same with a stellate block. What you're doing is that nervous system is instantly changed at that moment, and that is a window of opportunity for plasticity. So at that moment is where you want to drive the nervous system. And to your point, there's no doubt at this point that physical exercise has a very beneficial effect on the brain and nervous system. I mean, the neuromuscular system by weight is the largest sensory organ in your body, so it's a huge window to drive brain function. So how a stellate would correspond with a change such that exercise is beneficial afterwards. Absolutely, you see that all the time. We harness that window of opportunity. We also do it with psychedelics in our practice, where when we introduce that quick change, like a stellate or robust change in the nervous system, we introduce right at that moment the neurorehabilitation, because in a lot of people, and in people that are doing things like polyvagal, that sympathetic nervous system is driving so hard, it's very, very difficult to overcome with behavioral therapy. In the very least, it'll take longer to get there. But if you can provide an intervention that shuts it down, that's an opportunity to start working on building parasympathetic nervous system, such that if that sympathetic nervous system is coming up, you now have a robust parasympathetic nervous system that can now mitigate that and control that as it naturally would. So that's the kind of principle that we're doing in rehab a little bit.
So we have this kind of the big guns, and we have the fine tuning, and we're
Correct.
kind of going back and forth and saying, okay, here's the guns, here's the fine tuning, here's the guns. And I even think acupuncture is my perception of it is it's autonomic manipulation. You're manipulating the autonomic nervous system through the peripheral nervous system. And to a large extent, chiropractic is also a manipulation of the autonomic nervous system through the peripheral nervous system. I mean, all those things are doing more than just that, no doubt, but that's a big factor. And then we have, this, we have the big guns where we have the ability to directly affect, turn off, and change. And then we have the ability to have somebody like you who is understanding that change. So you're coming in and saying, okay, I know what your issue is. Yeah. Now that I open the window with whatever intervention you open the window with, then I can say, okay, this part of your brain, we're going to work on this. Right. We're going to work on that impact, that trauma, this, whatever happened to you. Right. And then kind of move forward. It kind of reminds me of one of the things that I did, and it's a little bit off subject. I apologize.
No, don't apologize.
When I was, when I was doing chiropractic, I had a nutritional program where I did a little applied kinesiology, which is kind of an autonomic manipulation as well. Yeah. And I would teach people how to eat well and how to understand what it feels like if your liver is stressed, what the emotions are associated, what the autonomic associations were, what the reflexes were, what the diet would be, what the exercises you would do to help that autonomic system function. Yeah. So that was a project that I had it seemed to be fairly successful. But I could just see how there's so many factors going on, and I also see the difference between an elite athlete and a regular person. Like, okay, this elite athlete, he changes a lot more predictably, and these healthy athletes generally a lot of times don't have peripheral nerve impingement problems when somebody who's maybe doesn't have as healthy of a system or as healthy connective tissue, or for whatever reason are not functioning as well. The other thing that I notice in testing people is that these elite athletes, when we test their brain, a lot of times their brain, even though they feel like they're not okay, they test better than the super doctors, the super intelligent, the scientists. Like, wait a minute, the idea that you're not smart is not real. Right. So we're kind of coming through with so much different information, and we need more experts like you to say, okay, well, this is the neuroanatomy, this is the neurophysiology. Let's quiet everything down. Let's look at this, and let's just walk through this, because obviously these people are lost.
That's the principle of treating everybody as the N of one, is going like, because I mean, really any intervention. So one of the things, I'm also it's been the last decade of my life, I've been chief science officer of a company I co-founded about 10 years ago actually a little less than 10 years ago, called Nausea. And we're bringing to market a neuromodulation device for the treatment of migraine. As a matter of fact, we were granted FDA's breakthrough medical device designation 2 years ago. We're the first device to be granted that designation for migraine, for the acute treatment of migraine. So in that, we've done a ton of clinical trials, and and we've put together all graphs that have been comparing our breakthrough device with different therapies. And what you realize, and that really has made an impression on me, is this idea that no intervention works for everybody. There's a population that it works for and a population that it doesn't. And that means in almost everything there's an unmet need. It's just relatively what is the size of that population. So if we work by averages with average interventions and follow these kind of rote approaches, there's going to be an unmet need. There's going to be a population that's not satisfied by the intervention. Whereas I think we can mitigate that to a certain extent and be more valuable to people by saying, okay, let's look at you as the N of one. Not look for that rote intervention. Let's find that package of modalities for you that'll work for you, specifically based on your specific presentation.
Yeah, and that's what I really like about, and I call it like scientific thinking. So scientific thinking is kind of what you're saying. It's like, hey, I don't know the answer. I have this data. As you're coming in, like I have this book of data, and I have this patient in front of me, and I have no idea what his problem is. Yeah. But because I have no idea and I have no projection, I'm open to seeing it. Yeah. So with my open mind, I can come in and come as close as I can to reality. And when we see reality, people get better because we understand what their problem is. Well, and I think what our system has developed is a lot of lost patients. I said they're just lost. They're outside of the system. Yeah. Nothing in the system is going to help them. Yeah. So they're just kind of stuck. Yeah. And it's like it's almost nothing worse or more frustrating and more debilitating than not knowing what to do, having a problem, not having any solution, not having access to the solutions. So I think that's this kind of work. I think what you're doing is, I think everybody would say it's groundbreaking, but
Yeah.
I think the biggest thing that I think about it is, it's coming from a humble place. It's coming from like, I don't know the answer.
Mm-hmm.
I'm not going to say what it is for this person because everybody is so different.
Yeah.
But I have enough tools to differentiate
Yeah.
to come a lot closer than almost any doctor out there.
Yeah, definitely,
and gets the real solution.
And that's
right?
that's really the tension, isn't it? Look, there's a value to clinical discipline.
Mm-hmm.
There's a value to evidence-based approaches. I'm not saying that we can just cowboy off and go into whatever we want to do. There's definitely a value to that discipline, and I think that's something to be respected in a clinician. At least I try to be as disciplined in that way as I can. But as I said, there's still an admitted unmet need. Like when you're looking at a study and you're seeing a sham, a therapeutic response of 60% and a sham response of 20%, and that 40% clinical gain. Well, that's the clinical effect. And then you also take even if you don't consider sham or the clinical gain, there's still a defined unmet need of non-responders. And so what do? So personally for me, I hope that I'm of benefit to the people with unmet need, but I've been attracted to those populations is hey, let me try and get into that try and innovate a little bit to serve that population that's not being met. And that's a privilege. It doesn't always work, and but at least we're trying, and that's where I'm trying to focus my career, particularly at this stage, is try and focus on the unmet need.
Yeah, I think that's kind of where I think we're all trying to come from. There's different brands or personalities of clinical people. One is that they didn't get better, but I'm smart. Something must be wrong with them, and it's a very arrogant attitude. But I'm just saying that we did everything else. They're just this person must be something's wrong because I can't be wrong, and that's just you're saying kind of the opposite. I'm pretty smart, but I'm wrong enough to know that I need to learn more. So now I'm getting more data. So basically, all that we're doing is collecting more perspectives and more data to hopefully get a little bit closer to what reality actually is for that person, and then kind of walk them through it.
No, listen, we're really privileged, and I know, I'm specifying that that's the way that I look at things. I know you're the same, and the people that are in our little community here are the same. We're really privileged to be at a time where, hey, there are new therapies. It's intersecting with the availability of technologies as simple as great ultrasound machines, or things like exosomes, or we're at a really brilliant time where if you have that intellectual curiosity, and you have a little bit of a background where you're kind of in the field where these therapies are coming together, it's amazing. We had a really privileged time. I think I feel that way.
Good. Yeah. Well, I definitely feel that way as well, and honored to be where we are, and open enough to learning and helping people. There's almost nothing better than helping somebody. When I talk to young people, I'm like, well, if you want to be successful, figure out how to contribute to your community. How do you become a valuable asset? Because valuable assets, you're going to be okay. Help more people, you're going to be okay. So the always question is, how do you help more people? And what I always say when I see people too is okay, if you have 7 problems and we fix 6 of them, you're not better. So what I'm always trying to do is figure out what that 7th problem is, so that ideally you don't have to come back and see me any more than you need to, right? So the ideal is, how do we see the truth, right? How do we get that last little bit? Maybe there's 20 problems, is it the amygdala, is it the insula, is it prefrontal cortex, what is it? So that's when you're able to focus on those things, you're able to understand those things. You were talking to me before a little bit about, hey, this therapy. So you were saying you do a stellate block, you take them back, and where they're activated. And that's one of the things that we do as well. So I always talk to people after they've had the block, because I know they actually hear me, right? And I actually had a person say to me that many people say to me after head injuries, I was pretending like I could understand what you were telling me. I could pretending like I could follow the conversation because I was embarrassed. And 10 minutes after the block, you're like, now I actually understand what you're saying. I'm actually able to follow the conversation. It wasn't like I was giving him, I had a complex conversation with him.
Yeah.
But at that time, it's the opportune time for them to hear what you have to say. It's like you're taking that time, and then you're taking that same person, and you're kind of with their mind open, using therapies where and I think I'd like you to talk about that. So you're maybe have them do different eye patterns with their eyes closed, look upon different parts of their consciousness, their focus on what happened to them. So I know that conversation is
certainly. So I can speak specifics on modalities, but there's one concept that you're getting on that's one of my favorites is this idea that any healing process, there's two components to it. One is that it involves a positive change in the nervous system, and that's how or at least I've gone about dissecting a lot of the psychotherapies, is breaking them into these kind of modular components and going, what part of it is actually really working, and what's happening at the level of the brain that this positive change happens, and therefore we can turn psychotherapy into a neurorehabilitation therapy to certain components. So that's one thing. The other is this idea that any positive change is by its definition transformative. So what I like to do is have a conversation with people up front just about their lives and go, okay, we're going to start a ball rolling, and this ball that's rolling is transformative. It's a positive transformation in your life. But where do you take it from there? What does it look like from here? So that they can keep that momentum going into a positive transformation that expresses in their life in a certain way. It's not just that moment of transformation, but it does come back to that conversation we're having where, that little moment transformation happens. I'm talking to a transferred person or transformed person, that this is a moment of transformation. Okay, they're heading into that direction. Another thing is a kind of a favorite concept is a lot of people come and they go like, well, I'm not sure if I can change, or, with people that are already like low points, I'm not sure if this can be changed. I'm like, well, a lot of times they've already started the process of change by coming into your office. They've already started that process. You've already started.
Yeah,
exactly. You hear it. So it's just keeping that kind of ball rolling, that momentum. But you asked a question about specific modalities. So different modalities are that you'd find in neurorehab. So intense neuromuscular stimulation, transcranial electrical stimulation, transcranial direct stimulation, oculomotor exercises, so moving eyes in certain patterns to activate certain specific parts of the brain. So for example, if I quickly look at something over to my left and look at a target, it took my right frontal lobe to do that. So if I do that habitually, I can activate the right frontal lobe, for example. Or if I'm pursuing a target to the left, I'm activating my left temporoparietal area. So if I do that repetitively, I can activate the left temporoparietal area, for example. But this is not anything I've invented. These are all modalities that are out there. In fact, in the field that in functional neurology, this is very bread and butter for that field. We're just applying it in a way that's hopefully, based on my experience, is a little bit more efficient, at least for myself in my clinical application. And it's in that paradigm of, looking at the behavioral stuff. Because in my view, when we were doing functional neuro-orthopedic rehabilitation, there was a rehab system that I co-founded with 3 other guys. And when we were doing that, what we were finding consistently was that there was a behavioral component that was not being met, in physical rehab. People go through the physical trauma, and people are describing these behavioral emotional components, and doctors are like, okay, so where does your neck hurt? Focusing on it. And look, don't mean to say that in a demeaning way, because you're looking for the part that you can fix, but a lot is still on the table. So they might be telling you about a dysregulated autonomic nervous system. They could be telling you about cognitive, decline or impairment, and that's all giving you a picture of what's going on in that nervous system, and the pain could be directly related to that. So you want to kind of put that full picture together. Other modalities, virtual reality. We use virtual reality in a prescribed way, and these sorts of. I think I covered a lot, but that's just an idea of some of the things we do.
That's great. So what I want to do is I'm going to take maybe a case that I see, and I want to see how you understand what happened. So let's say so.
So before we do this, so this is it's a great teaching tool, but understand that person's not in front, so you have to kind of simulate how they would respond in an exam, because that each test that you're doing in an exam is a potential bifurcation in where that goes. So
basically, what sparks in your mind is what's a probable cause of this situation? So let's say that a common thing that I'll see is a whole picture of dysfunction related to like C1, where they have trapezius tightness. They have difficulty focusing. They have difficulty hearing. They have tinnitus. And they have, some POTS or some heart dysregulation or all those things. Yeah. But then you treat them and those things get better. But but to me, logically, as I go through them, I'm like, okay, well, they got trapezius. That's spinal accessory nerves. It's a C1. Okay, now they have this inability to focus their hearing. Well, that's the facial nerve. It's the PDS muscle. That's the auditory canal, their pressure. They have tinnitus. They have blood flow to their brain. So I'm like, okay, well, that makes sense. I got blood flow to the brain. I got the control of the eardrum, and I got also the control of the pupillary constriction and dilation. So, okay, I kind of understand where this is maybe going, and then when you start to have this accumulation of like, oh, everything is pointing to this spot.
That's right.
Then you start to understand, hey, this is what's happening. And I think you're looking at different data maybe, but you're kind of coming to the same thing. So if I have a patient it's not unusual to have a patient come in who's been assaulted, like raped, and it's, I think, such a multi-layer trauma, multiple parts of the body, multiple parts of your brain, that's happened to. But I have seen on many occasions, that somebody comes in, they get a stellate block, and they're quiet. Eyes start to blink, and they cry really hard for 20 minutes. And then they look at me and they say, well, it wasn't my fault. This is what happened to me. I couldn't talk about it. I couldn't think about it. But this is what happened to me. And you know what? It wasn't my fault. And I'm going to be okay.
Yeah.
So it's kind of it's a weird thing to say because I've seen that case.
No, not weird.
That story
not,
about
not
100 times. But I just want to say, neurologically, from your point of view, I know there's all kind of bells going on. So what do you think happened?
Well, so first of all, when you're expressing what you expressed at first is just good neurology, is a principle in neurology, which is no matter how many things someone has going on, you're going to isolate you want to have a principle of approaching an exam to isolate all of these symptoms to one single lesion. What level of the neuroaxis, where in the nervous system could there be one single lesion that accounts for everything you see? That takes discipline, and it takes understanding and experience to do that. But because you don't go, oh, well, that could be this, and it could be this, and you end up with this vague collage of all these potential things. That doesn't help anybody. So what you were expressing at first was just good disciplined neurology, the principle of trying to isolate it. So that part's definitely not weird. The part where somebody has an intervention and they have a certain perspective where they can have this meta appreciation of something that they've been through, one of the things that I think of, and the hairs are standing up my arms, because that's a moment, is for you to become introspective to a point. Now there's kind of, think of it as dysfunctional introspection. So people that are high anxiety or depression, or have that, a lot of them have been through all sorts of trauma, whether it's emotional, physical. Generally, one of the very common characteristics of that is hypervigilance. The body checking, am I okay? What does this mean? What does this mean? What is that hypervigilance? So that's I guess a form of introspection. But this meta appreciation where you can rise above it all, of the trauma, and go, okay, now I see how all the pieces fit together. I find meaning, I find resolution. That depends on a good brain. Okay, and this is one of the things that I look for in therapy to describe to people is, in order for you to literally create the space internally to think things through, whether it's a complicated math or a complicated life problem, you literally need to activate those parts of your brain that are associated with space, like your parietal lobe and your temporal lobe. You've got to visual spatially in your brain. You've got to create that space. That's brain activation. Now, if you're in a hypervigilant state where your sympathetics are cranking and you don't have a good brain to do that, you just can't neurophysiologically get to that position of establishing that perspective in your brain to kind of rise above it. And all you are is in the milieu of these really aversive responses and really troubling symptoms. So when you were speaking like that, I'm like, okay, you kind of lower the water level of that some sympathetic activation, and now you kind of at this meta perspective of rising above, and I go, okay, well, I can see how that relates to that, and you know what, I've got some perspective on it now. That makes a lot of sense to me. I kind of see it in that way. And as a matter of fact, that's kind of one of the objectives of therapy, is to build that good brain in conjunction with just cognitively, emotionally trying to get perspective on things. So it's like building the machinery of perspective in that way.
Excellent. Yeah. It's a good way. That's a good interpretation. Yeah. Another thing that I see, which is more maybe common for athletes, is that I'll see, these athletes that are, maybe they're overtrained, they get agitated, right? They're not performing as well. And they find they come in and they get a stellate block, and they go from like not performing as well, and these are like super elite guys, and all of a sudden they're at the top of their game, and they're not only at the top of their game, they're thinking more clearly, they're making better decisions, their reflexes are faster, they're stronger, they have better vertical jump, and there's like studies, there's studies that prove that that's the case, that there's Dr. Shawn Mulvaney did a study on that for the Special Forces, where they showed that using the Jokel research, better reflexes, and all these different, better thinking process, all these things changed. And then I go on to like the athletes that I see where, okay, this is how I know I'm going to win. This is my process. This is part of my training now, where that overtraining has almost a next day recovery. So I guess that's a similar line. But what comes to your mind when you hear these stories?
Well, first of all, the idea of what you're talking about with Dr. Mulvaney, who I had the privilege of meeting him. I know he's a good friend of yours. He's just really inspiring guy. When you're talking about improved cognitive function with an autonomic intervention, my first response is, that's fascinating. And we're trying to do that in our practice right now, where we're accumulating data. I think that's one of the components of, I didn't used to think this way as a younger clinician, but as I've got a little bit older, I kind of feel that responsibility is like, okay, if we feel we are delivering this benefit, I think it's our responsibility to gather data. It's a cumbersome task. It's not easy. It takes some discipline, but we should gather that data and contribute to the field. So I hope he's continuing to gather that data, because I think it's fascinating. And certainly in our practice, we're gathering that data. It can be difficult when you're putting in multiple interventions and it's not in the structure of kind of an IRB approved study, but you can still, there's levels of evidence and you can still contribute in that way.
Well, certainly. I think I'm not sure if he's on 36 studies on published studies on that stellate block at this point, or I think it's probably more than that. I don't know the exact number, but it just keeps every time I look at it, the number is going up.
It's highly productive. I've read a lot of those papers.
Very, very productive.
A lot to respect.
So it's just interesting to see those changes and get a different perspective on, hey, why is this happening? Another thing that I see happen is the heart rate and the rhythm problems being affected, by, the stellate block and C1. One case that stood out to me was a woman who had her heart rate was 40, and she had POTS, and so she would pass out if she stood up, and she was scheduled to get a pacemaker because she was not functioning well. And we did the block. And within 10 minutes, her heart rate was 72.
Wow,
and then it started to dissipate. So we came back the next week and did the block with something that had a more lasting anti-inflammatory regenerative effect. And then it's been 3 years, and her heart rate's been normal. She never had to go through that.
It's fantastic.
So, and that C1 hydrate section, is my point, is probably enhancing the function of the sympathetic chain and the vagus nerve and the brainstem. But that's just my opinion, with not being as much of a neuroscientist as you are. So how would you
first of all,
that
POTS, or postural orthostatic tachycardia syndrome, is kind of that's a very common thing that I deal with, because oftentimes it masquerades as panic attacks and anxiety, or rather the symptoms associated with anxiety and panic attacks manifest as a consequence of dysautonomia. POTS is a subcategory of the general field of dysautonomia or autonomic dysregulation. So I'd happen to see a lot of that. So the concept that you can intervene in POTS and then have smoothing out of cardiovascular function is not terribly surprising, and I think it's fantastic that you can do it with a single intervention like you can do that you just mentioned. And certainly we try to do that. I'm hoping to gather some data on that, but what I should say is kind of what's interesting is just so we know that I think what we may recognize is we've gone over these various domains and manifestations of dysautonomia. We spoke about hyperperfusion of the brain and these cardiovascular changes, but it really can manifest in many ways, including gut dysfunction. So people can have alternating diarrhea and constipation, and vomiting and throwing up. It can manifest in different ways, and I think what the lesson here is that we can't treat all patients as the same. We can't treat them as an average. We need to look at saying, how is this manifesting in this individual, and then establish some baselines, and what are we going to monitor? You set up your own little study in each patient in a disciplined way. Okay, what are the metrics that we're going to use to measure success? Those are metrics that we might instill, but hopefully do that in agreement with the patient. Mm-hmm. What does your life look like when it's better? Which, incidentally, for people that have had head injury that's difficult, a lot of times they can't even project themselves into the future. They'll describe that. They'll start saying things like, I can't even imagine myself into next week. And by the way, my body doesn't even feel like my own. I feel weird, that disassociated kind of dysmorphic kind of thing. So the point is it can manifest in different ways, and that's why we want to assess each patient individually, set their own baselines on some, really good metrics, and look at pre and post, and that's how I would approach it. But that's what comes to mind when you're talking about that.
Yeah, great. And now everybody has their cases that kind of their memories that inspires them. So what was a case that inspired you that that you feel good about being a part of, you feel honored to be a part of it, kind of?
Man, like all of them. I think as you get older, man, you just start appreciating that life is difficult for a lot of people, and you start becoming a little bit more appreciative of people's suffering and the depth of what that suffering means. Everybody in some way is going through some kind of challenge, and in that there's typically something that's really that you can associate with, that you can be empathetic for, and can inspire you in a way. So I mean, they're all like that. I think I don't know, just a couple. One of my most recent ones was not terribly complicated. Just a lady that came to see me with depression, and wasn't finding success really anywhere else. It was a treatment-resistant depression case, and 3 weeks later and hadn't exercised in a long time, and 3 weeks later we're doing a hike in piping hot Phoenix in the summer, with no sign of depression and no suicidality. And another thing, it's kind of weird is a lot of people reach out to me, and it's not because I'm particularly fantastic as an individual, but it's the field that I'm in. And a lot of people think that everyone's doing okay and everyone around you is doing better than you're doing. But that's often not the case. A lot of people are kind of having these burdens. So a lot of those really parts that feel good are when you can see someone reconnecting with family, I think, enjoying their life more and not having to carry a burden that they're keeping in secret, and, realizing that, hey, I'm part of a bigger whole here and I'm not the only person, and to alleviate the suffering, but also see them kind of reconnect with life in a big way. So I don't know. I don't think there's any one case, but those are all inspiring. I have a hard time sometimes when people it happens often when people come in and they're talking about what they're going through. In the back of my mind, I'm going, a lot of times it's difficult to feel worthy of sharing that with somebody. Somebody's suffering. A lot of times people are going through such a hard time that you feel unworthy of even just carrying that burden with them for a little bit. So all of it's humbling and all of it's inspiring, to me. I'd really appreciate it more. As a younger clinician, I probably wouldn't have, but in the last decade or more, it probably has to do with having kids and, getting older. I find it all humbling and inspiring in some ways. So. Yeah,
it's inspiring work. I mean, it's outstanding, and really appreciate your work.
Yeah.
How does somebody contact you? Somebody wants to get a hold of you. Somebody wants to see you. How would they get a hold of you?
Yeah. So Neurogen is the name of my practice in Phoenix, Arizona.
Okay.
That's NEU like neuro, and regen like regenerative. NEUREGEN.com. Just on the website, they can contact me through the website, and that's how you get a hold of me.
Oh, good.
So, yeah.
And what else would you like to share with your community, with the world about your work that we haven't gone over?
Our work.
Our work. We haven't.
We haven't in similar. That's the exciting part.
Yeah.
Well, first of all, what I'd like to share is just that, man. It's just a lot of people are suffering, burnout, feeling like they're emotionally overwhelmed at the end of things. You're not alone. Mm-hmm. That's the first thing. And not all of this is a medical problem. I don't like people to think of getting help with those things. You don't have a medical problem. You have a life problem. It's life. And first of all would be connect with people. It doesn't have to be a medical professional. It's just connect with somebody. That's the first step, is connecting with somebody and appreciating connection that you have with people around you. And some people don't have a lot of loved ones around them, but pursuing that connection with somebody is certainly a road to a better place, as well as truth and reality. Just being honest about things and admitting that you're in a place and asking for help. There's nothing wrong with that. I'd just like to share that. And a lot of people, you feel like you're in a tough place, but truth, connection, dealing with reality, not running away from things. That's the path to the way out of here, and it's a worthy path.
Yeah,
there is health. Health and just wellness. Everybody deserves that.
Yeah. Well, thank you very much. It's been a great honor.
It's my honor, Shawn.
It's my honor. Tell you.
Appreciate your friendship, man, and it's always inspiring being around you. The people you have around you is inspiring, and I always enjoy our time together, including paddleboarding.
Oh yeah, that was wonderful.
You took me out today, so I really appreciate that. So thank you.
One of my loves. Yeah. Thank you.